Welcome to Updates from ASCO. During this seminar, all participants will be in a listen-only mode. There will be a question-answer session at the end of the presentation using questions submitted through the Q&A feature. Please remember the information provided in this web seminar is not intended as a substitute for your physician's guidance and care. We would like to thank Blueprint Medicines, Genentech, Decipher, and Novartis for their unrestricted educational grants for today's webinar. My name is Sarah Rothschild. I'm the Executive Director of the Life Raft Group, and I would like to introduce our presenters for today. Dr. Andrew Wagner is the Deputy Chief Medical Officer at Dana-Farber Cancer Institute and the Medical Director of Adult Ambulatory Oncology. As a medical oncologist and translational researcher in the Center for Sarcoma and Bone Oncology and Associate Professor of Medicine at Harvard Medical School, Dr. Wagner focuses on the treatment of patients with GIST and sarcoma and conducts laboratory research and clinical studies to identify new targets and treatments for these diseases. He received a PhD in biochemistry and molecular biology and an MD from the University of Chicago Pritzker School of Medicine. Dr. Herbert Loong holds conjoint appointments of Clinical Associate Professor in the Department of Clinical Oncology and Deputy Medical Director of the Phase 1 Clinical Trial Center at the Chinese University of Hong Kong. He is also the current and founding convener of the Prince of Wales Hospital Adult Sarcoma Multidisciplinary Team. And Dr. Loong obtained his medical degree with a distinction in surgery from the University of Hong Kong in 2003. Dr. Loong is a recipient of the European Cancer Congress Fellowship Grant, the American Society of Clinical Oncology Annual Meeting Merit Award, and the Hong Kong College of Physicians Young Investors Award. So with that in mind, I'd like to now hand this off to Dr. Loong to begin the first presentation.
Thank you very much, Sarah, and good morning, good evening, everybody. I'm Herbert Loong from Hong Kong, and it's a great honor to be able to speak to the Life Raft Group, especially coming from Asia. So I think in the next 20 to 25 minutes, I would start off with some updates from ASCO 2022 on the emerging roles of ctDNA in gastrointestinal stromal tumors. And of course, Dr. Wagner would also follow on with some further updates from the conference. And we also look forward to a very fruitful Q&A session after our two talks. So let's begin. These are my disclosures. And for my part of the talk, in the next 20 to 25 minutes, I want to cover these particular aspects. I think the first question is, what is ctDNA? Second is, what are the applications of ctDNA in routine oncology practice? And thirdly, are there specific data on the use of ctDNA in the treatment of GISTs? What are the latest updates from ASCO22 specifically to this topic? And certainly this year for ASCO22, 2022, ctDNA was the main theme. And also, just to round things off, I do want to give a quick update on the Intrigue study, which is the second-line use of Imatinib versus Sunitinib. So maybe by way of introduction, what is ctDNA, or in full, it's actually circulating tumor DNA. Well, in actual fact, there are cell-free DNA, which are small DNA fragments that's actually in the blood circulation. And these are actually released into the bloodstream because of the fact that cells do turn over and some of them die. And then therefore you can pick up these DNA. Now, in healthy individuals, in actual fact, most of the cell-free DNAs are actually from your blood cells, which are in your bone marrow, and then therefore they get released. But there are also small DNA fragments from circulating, which are circulating from tumors in cancer patients. In actual fact, this specific technology of using ctDNA for medical diagnosis was founded about 10 to 15 years ago by one of the professors at our university, Professor Dennis Lowe, who used this technique to detect Down syndrome in babies of mothers. So ctDNA is actually a short fragment versus normal DNA, so they're very small molecules. And actually, the other thing is they have very short half-lives. Now, when we talk about ctDNA, we would always compare it with tissue testing. And that is if you get a biopsy from the tumor, and how does this compare in terms of doing a diagnosis with tumor tissue, either through surgery or through a biopsy versus actually taking blood and then trying to get the DNA material from the blood. Well, to begin with, if you think about getting tissue, typically in order to get the tissue, it can be relatively invasive. You probably need to do a surgery, you need to do a biopsy. And in cases where you have multiple tumors, when you actually take tissue from one tumor, it might not necessarily represent all the tumors that are in your body. On the other hand, the great thing about ctDNA is it's just drawing of blood, so it's actually less invasive. It also gives the opportunity for you to monitor patients over a long period of time at different time points, because of course, getting biopsies through a long period of time is not going to be feasible. There's also a good chance of it to be representative of multiple tumors that are in the body, as opposed to just the tumor that you're biopsying. And it's actually also quantifiable in terms of the amount to actually see whether or not you have a lot of tumors or less tumors. Now, in terms of using ctDNA, there are various methods of why we would use it or how we would use it. To begin with, we would like to use it for molecular profiling, so we can actually then determine what type of tumor you have. At the same time, aside from identifying what type of tumor, for patients who are under treatment, especially in lung cancer, for example, it's also quite well established now that we use this technique to monitor patients through treatment. There's also a potential for using it for early cancer detection, where if you actually do imaging such as X-rays and CT scans, you might not be able to find a tumor, but through ctDNA, you'd be able to find these tumor DNA fragments. And also for monitoring of patients after their initial surgery or main treatment. So one of the key advantages of ctDNA is the fact that it can account for what we call both spatial as well as temporal heterogeneity. So what that really means is it actually encompasses potentially all the tumors in the body. So you could get genetic material from all the different metastases, or all the different clones. And of course, the other thing is, again, you can monitor these patients over a period of time at different time points. So it gives you a temporal sort of assessment as well. Now, that's just the background of ctDNA. So what data do we have in the use of ctDNA for patients with GIST? Now, let's take a quick look in terms of how we have come in terms of our treatment of GIST over the last 10 to 20 years. And certainly about a decade or a decade and a half ago, there really wasn't any treatment. And it was Imatinib or Gleevec, which was the first treatment that has been established. And certainly, I think that really changed the landscape of how we treat patients with GIST. And moving forward from then, in actual fact, we have established second-line treatments, third-line treatments, as well as fourth-line treatments, where in actual fact, the duration of response, or which means the amount of time that patients are able to have their disease controlled, do tend to shorten as you go on to the multiple lines of treatment. There's also a smaller number of patients who may respond to treatment as opposed to first-line use of Imatinib. Now, the reason behind that is the fact that if patients are being treated over a longer period of time, and as the disease progresses over a longer period of time, in actual fact, the tumors in the body become more and more resistant to Imatinib. And there's also a development of what we call potentially secondary KIT mutations, whereby the use of first-generation drugs such as Imatinib may not be encompassing enough to cover all the mutations. Now, the other thing is we also know that as time progresses, when you are giving patients more and more treatment, you start to develop various clones, whereby you actually have different deposits within the body with different genetic signatures, which may respond differently to different types of treatments. And you probably need a bit of a what we call a broad-based approach to cover more and more of these mutations as time progresses. And a single use of, say, Imatinib, which is very specific, may not necessarily be the best way. And at the same time, this goes back to the issue of ctDNA, because with ctDNA, we are able to obtain the DNA material from all the tumors in the body, potentially, and we could then subject it to what we call next generation sequencing, which is a more broad-based approach in terms of analyzing whether or not patients have specific, the tumors harbor specific mutations. And sometimes we can even identify non-KIT dominant mutations, which are becoming more and more important. And when we think about a resistant GIST. Now, some of the older data, and this is honestly not too old, this is just from 2 years ago, which is looking at the use of ctDNA in the management of GIST patients. This is a paper that's come out of the Miami group from Dr. Trent, and Dr. Ashad, I believe, was one of his clinical fellows. And what they have really established is the fact that the identification of ctDNA and then using it for diagnosis or analysis is feasible, but mainly in patients who have a relatively high disease burden or where the disease is actually becoming more and more progressive. It's also important to note that they also used a G360 or a Garden 360 assay, which is something that is commercially available pretty much also in most jurisdictions around the world, and certainly available in the US, as well as in Hong Kong and other places as well. Now, specifically, I think going into ASCO 2022, which just concluded about a week ago, there were a couple of papers which looked at the importance of ctDNA in GIST. And certainly, I think this probably is one of the prominent papers, which was presented by Dr. Cesar Serrano, which actually looked at ctDNA and an analysis from the Voyager phase 3 trial. And I just want to spend the next couple of minutes walking you through his presentation so that you would have a better understanding of where we stand. So just to recap, the Voyager study is a study consisting of patients who have been treated in the third line, who are actually in the third line or fourth line setting, where patients were randomized to either the use of Avapritinib, which is the investigational drug in this particular clinical trial, or the standard of care, which would be Regorafenib. The primary endpoint was progression-free survival. And just again, to recap, this is actually looking at secondary mutations of patients who have GIST. And you can see that the common secondary mutations are mutations in exon 13 and 14, or exon 17 and 18. And you can see that in actual fact, Regorafenib, as opposed to Avapritinib, actually have different sensitivities in terms of coverage of these mutations. So therefore, that can be the fundamental reason why their activities are somewhat different. And what you can also appreciate is the fact that in Avapritinib, there's generally resistance in the coverage of the exon 13 and 14 mutations. Now, this, of course, was presented, I believe, last year, where in actual fact, the trial's primary endpoint, which is progression-free survival between Avapritinib and Regorafenib, showed really no statistical difference. And the trial was deemed a trial which did not meet its primary endpoint. Now, for this particular presentation that Dr. Serrano presented, this was a presentation of the translational research that was associated with the clinical trial, where patients at the beginning of the trial and also at the end of treatment were also subjected to a very simple blood-based DNA test, which is using the Garden 360 platform. Essentially, what the aim of this particular presentation is number one, to look at the landscape of KIT and PDGFR alpha mutations in patients with advanced GIST, and also how ctDNA may affect patients' outcomes. Just a quick rundown. In the patients who were recruited into the clinical trial, almost up to about 500 patients, they were actually put into two groups. Half of them had Avapritinib, half of them had Regorafenib. And ultimately, out of the 476 patients, there were 333 patients where, in terms of the blood test, they were able to detect the ctDNA. So that's 86%. And in actual fact, if you look at this particular number, it's actually quite encouraging, given the fact that in the prior publication that I showed from the Miami group, the numbers were not as high, as in the technique of ctDNA at that time did not pick up all the number of mutations. But specifically in this particular group of patients, about 86% of patients were able to have mutations in their blood identified through the Garden 360 platform. So this is just a graph showing the number of variants, so the number of mutations detected in the blood when you plot them, when you plot all the patients into this bar graph. So what this graph really means is the majority of patients in their blood actually had they were able to detect one or two different mutations from the GIST tumors in the blood. But there were also patients who had 3 or 4 or even more mutations. And certainly, I think it shows the fact that there is a clear element of tumor heterogeneity in terms of the patients who are recruited into this clinical trial. Now, this is probably a bit more complex, but again, looking at the landscape of the GIST mutations, and what you can see is predominantly patients, of course, continue to harbor the primary KIT mutations, which is exon 9 and exon 11. Now, if you remember the diagram I showed you previously, there's also exon 13, 14, which is responsible for the coding of the ATP binding pocket, or exon 17, 18, which is responsible for the activation loop. And certainly the majority of the patients also had detectable mutations in their blood of DNA showing changes in these two areas as well. Now, going into the actual data itself, so this is where things might get a little confusing, and I'll try to walk you through this. So this is actually looking at patients who are recruited into the trial, where in patients who actually had tumors harboring mutations in exon 13 and 14, in such situations, what they found was the fact that if the patients actually had exon 13 and 14 mutations, if patients who were given regorafenib had a better progression-free survival, as well as overall survival, compared with patients who were given avapritinib. And I guess this is biologically fundamentally explainable, given the fact that if you have mutations in exon 13 and 14, the coverage of avapritinib is actually not very good. And therefore, the use of avapritinib may not be able to control the tumor as well as regorafenib. Now, looking at situations where there is no mutations in exon 13 and 14, so where the I suppose the Achilles heel of avapritinib is not present, what we found is the fact that in situations where there's only exon 17 or 18 mutations, there seems to be a better response in patients who actually were given avapritinib. As opposed to patients who actually had these mutations. And however, the presence or absence of mutations in exon 13 and 14 did not make any difference whether on situations where you were given avapritinib. So I think what this really echoes is the fact that if there is presence of exon 13 and 14 mutations, avapritinib is a weak drug, and therefore this probably explains why the trial did not meet its primary endpoint. On the other hand, looking at regorafenib, which is a bit more broad-based in terms of its coverage of both exon 13, 14, as well as exon 17, 18, whether or not you have mutations in the ATP binding pocket or the activation loop, there really is no difference. So it seems to be a bit more broad in terms of its coverage. And in situations where the ctDNA was not detectable, it seemed as though that patients who had avapritinib, there was quite clear difference in terms of progression-free survival behavior in patients who were treated with avapritinib or regorafenib. And in situations where the KIT was actually absent, so there seems to be a stronger amount of activity in patients treated with avapritinib. So overall, the key findings is the fact that performing a liquid-based NGS panel, such as the one in this situation, which is the Guardant 360, it's feasible in patients with advanced GIST who have had more than or equal to 2 lines of therapy. I think this trial shows the fact that, or this presentation shows the fact that not all patients are the same, and the molecular signatures of these patients are actually quite heterogeneous. The results of the ctDNA sequencing also correlates with treatment outcomes. And in situations where there are detectable exon 13, 14 mutations, which is responsible for the ATP binding pocket, this correlates negatively to avapritinib activity. And on the other hand, regorafenib, which is our standard of care drug in the 3rd-line setting, appears to have relatively broad coverage of secondary mutations. Now, there was actually quite a few other smaller presentations of ctDNA at this year's ASCO, but this is probably one that also is probably worth mentioning. And this was actually a poster that was selected for poster discussion, which actually looked at the KIT-resistant mutations identified, as well as treatment outcomes in patients with advanced GIST. And again, this is a multi-country collaboration together with Guardant Health, where they looked at GIST patients who actually had the ctDNA done. There was 104, and out of the 104 patients, in actual fact, 62% of these patients had KIT alterations detected in their ctDNA assay. I think the take-home message, though, is what they found is amongst these 64 patients, all of them had the KIT mutation that was detected, but on the other hand, also had at least one or other different genes or biomarkers. And what that really means is there is a potential for these patients to have their tumors subsequently progress or worsen because of the fact that there are presence of other genetic alterations, which is not just KIT dominant. So therefore, I think what that really means is looking at the treatment of these patients in the later line setting, we might need to have a broader base coverage in terms of our treatments and not specifically just looking at the KIT pathway. Now, lastly, in the next 2 or 3 minutes, I do want to give a quick update in the Intrigue trial, which is the phase 3 randomized open label study of ripretinib versus sunitinib in advanced GIST patients who have previously been treated with Imatinib. So this was actually initially presented in the ASCO plenary series, I think in January this year, as a web-based presentation. And there was a quick update on this at the actual ASCO meeting a week ago. So Dr. Michael Heinrich was the presenter on behalf of the group at this particular meeting. And just a quick recap in terms of where ripretinib is as opposed to the other drugs. RI here is ripretinib, and you can see again it has pretty good coverage in the primary mutations, at least in the laboratory. It has also good coverage in the activation loop mutations, which is again exon 17 or 18, and some intermediate coverage in the exon 13 and 14 space. So the clinical trial itself was designed such that this is a second-line study, and it was pitched against sunitinib. So these patients who were recruited into the trial had to have progression on first-line treatment with Imatinib. This was a large international study covering all corners of the globe, and patients who were entered into the trial were randomized on a one-to-one fashion. So half of the patients were actually given ripretinib. The other half of the patients were given sunitinib. The primary endpoint of this particular trial is to look at the progression-free survival. Now, in actual fact, these results were already presented in January, but again, represented here in June. And the overall findings is the fact that in patients specifically with KIT exon 11 mutations, as well as for all the patients who were recruited into the clinical trial, there was actually no statistically significant improvement in the use of ripretinib over sunitinib. What is probably more interesting is the most common side effect of ripretinib is quite different from sunitinib. And in actual fact, most of the side effects were relatively mild. And this, of course, is quite different from the side effects that we get when we put patients on sunitinib, which, of course, includes high blood pressure and the development of blisters and cracks in the hands and feet, such as also known as hand-foot syndrome. This actually looks at the progression-free survival of patients, and it seemed as though that patients who had tumors that harbored KIT exon 9 mutations, they seem to do better if they were given sunitinib as opposed to ripretinib, but overall there does not seem to be quite a clear difference in terms of its efficacy. So again, going back to the side effects that I've mentioned previously, the side effect profile, however, is quite different between the two drugs. And I think that is probably something that a lot of clinicians are now considering in terms of the positioning of this particular drug. Also, in terms of the side effects, aside from the fact that the pattern of side effects are different, the severity of the side effects are actually quite different as well. And certainly in patients who were treated with sunitinib, there were some patients who had what we call grade 4 toxicities, which is a relatively high grade toxicity, whereas patients who were treated with ripretinib, most of them were at most grade 3. So, in terms of how patients view the use of these two drugs in terms of side effects, they of course also measured the quality of life of patients who were subjected to these treatments, as well as the main issue of skin toxicity. And it seemed as though that patients who were put into the ripretinib group enjoyed a better quality of life, and of course also a less skin side effects. And that of course is something that we also consider when we choose the treatments for our patients. So in conclusion, although ripretinib did not meet its primary endpoint to show that it would be superior to sunitinib in terms of progression-free survival, what they found was the fact that the median progression-free survival was actually comparable though between sunitinib and ripretinib. And I think the bring home message of this particular talk to our discussion today is the fact that they're also looking at whether or not the mutational status of the different GIST tumors in the different patients may actually impact the effect of these drugs. And they also are looking at ctDNA. So I believe in the next ASCO or maybe subsequent meetings, we will be getting more and more information that can actually help us in our discussion. So with this, I would like to end. I'm sorry if I've gone a little over time, and I'll pass the mic over to Dr. Wagner.
Thank you, Dr. Loong. Thank you, Sarah, for inviting us. It's good to speak with all of you. Just looking at the list of participants, I know a few of you, and I'm happy to meet the rest of you. If you're overwhelmed by that presentation that Dr. Loong just gave, so am I. It's a lot of information, and I just want to explain a little bit about meetings like ASCO and other meetings. There's a full range of things that are being presented, from things that are merely ideas that are really small studies. And actually, in a minute, I'll show you a couple of really small studies that have been presented, to other studies, such as the few that Dr. Loong just presented, that are large studies, somewhat mature in their data and their analysis. But some of these are still not peer reviewed. They haven't been debated and discussed among all of us. And so the conclusions and what to do with them changes over time. So for a lot of this information, especially the information about the circulating tumor DNA, we're still trying to understand, what does that mean and how do we use it in clinical practice? So it's all really interesting to us, and the analyses are fascinating, and it's great that they're being incorporated into clinical studies, but it's going to take a lot more time for us to figure out what to do with them. So don't feel like, boy, I'm not quite sure what that means. Maybe I should go get circulating tumor DNA, because we still don't know exactly how to use it. And this is all part of how we learn and how we share information as we learn it. So anyway, with that preamble, let me share some data from these studies. I was going to share some information from 5 different posters that were presented. And posters, I'll show you pictures of what they actually look like, they tend to be more preliminary. And so the amount of information we have from the studies is usually a little bit less. Here are my disclosures. And these are the 5 abstracts that we thought were particularly of interest to discuss with all of you related to GIST. So 2 discussing novel drugs, new drugs that are being studied for treatment of GIST. And I'll go through all these in more detail. 1 asking a question about whether the sequence of drugs makes a difference. And this one specifically is asking about avapritinib and ripretinib. It doesn't matter which order a patient receives them. And the last 2 are a really common question for many of us in the clinic when we're meeting with you, which is, if I have metastatic GIST, do I need to stay on Gleevec forever, or can it be interrupted? And this question has partially been addressed in the past, but is also being asked a little bit differently by these 2 groups here. So I'll just go through these in a little bit more detail. I'm I'm just going to show you pictures of what the posters actually look like. And then I'm not going to read through these parts of it, but I'm just going to pull out the conclusions. So this is a study of a novel drug called Imatinib. And yes, we also have problems pronouncing some of these drugs in patients with GIST. And in this presentation, they're focusing on those patients who have succinate dehydrogenase deficient GIST in particular. And just to explain this a little bit, as you know, I'm sure most GIST are driven by mutations in KIT, and another subset is driven by mutations in a related gene called PDGF receptor alpha. But there's another group that used to be primarily called wild type GIST, which now is known to have alterations in one of the 4 genes encoding protein called succinate dehydrogenase. And they all have this shared quality of not expressing the protein, succinate dehydrogenase, the complex. And so we refer to them as SDH deficient GIST. And these are not driven by KIT mutations, but without having that enzyme, SDH, you accumulate a compound called succinate. And that can have a variety of actions on the cells that presumably drive it to form a cancer. And those include alterations in gene expression, how different genes are turned on or turned off, because of how it can alter how DNA gets extra chemicals stuck on it called methyl groups, and that can regulate how genes are expressed. And it also appears that accumulation of succinate can lead to overexpression, overproduction of a protein called vascular endothelial growth factor, or VEGF. And many of the drugs that we do use currently in SDH deficient GIST, such as sunitinib and regorafenib, are also inhibitors of the VEGF receptor. And that's partly why they have activity against this type of tumor. So that's sort of a background on SDH deficient GIST. And in this study, they use this new compound called Imatinib. And this has activity against a variety of different kinases, including KIT and PGFR and VEGF receptor. And that's similar to what we would see with drugs like sunitinib and regorafenib. And it also has activity against the FGF receptor and a bunch of other kinases. And this study is what we consider a phase 1/2 study. Phase 1 studies test different levels of the drug, different doses of the drug. And phase 2 studies look at how well the drug works, with the goal to look at how safe it is, how tolerable it is, what the drug levels are in people, and how well they work. And to be eligible, the patients had to have GIST that was resistant to imatinib or other inhibitors. And this medicine was given orally on every other day schedule. And so they enrolled 39 patients into the study. 31 of them had mutations in KIT or PGF receptor alpha, as would be expected, just based on the normal population of GIST patients. None of these patients had tumors that shrunk significantly. 13 patients, though, had disease that remained stable for at least 2 cycles, and some of them were more prolonged. So 6 of the patients had SDH deficient GIST, and importantly, 2 of the patients with SDH deficient GIST had significant shrinkage of their disease, and the other 4 had stable disease, including 1 that had stable disease for over 36 months. So this was intriguing that there could be some activity, some particular activity against SDH deficient GIST from this compound. Some of the side effects that were seen were low blood counts, constipation, weakness, and elevated liver tests. And that's what we learned from this, which is this compound that seemed to have activity in a small number of patients that were treated with SDH deficient GIST, but pretty significant activity. And it'd be interesting to see how this continues to be developed and whether we can continue to explore it in this patient population. We don't know how it's working. It could be, as I mentioned, through the VEGF receptor inhibition. There's also some data from the lab and even in some patients that the FGFR pathway might be important, in particular in SDH deficient GIST. And since this compound can inhibit that pathway, that could also be important. Or there could be other pathways that it's inhibiting that might be important in this disease. So again, this is preliminary. It's interesting, and there's more to learn if we can enroll more patients into a study like this. Now, another study was looking at a completely different approach to treatment of GIST, and this was from my colleague Suzanne George and other collaborators of a compound called DS6157A. Again, this is a phase 1 study, which was looking at the safety and tolerability of this compound. Now, this is different because it's what we call an antibody drug conjugate that's targeting a protein called GPR20. GPR20 is expressed on the surface of GIST cells and pretty uniquely on GIST cells and not on many other cells in the body. And what an antibody does, antibodies are what we normally make to fight infections, but the way they work is that they bind other proteins very specifically, and they can be engineered in the lab to bind against any protein. In this case, one was engineered to bind to this GPR20, and it brings this drug conjugate means that it has a drug linked to it, and actually a type of chemotherapy. This is called exatecan. It brings that chemotherapy directly to the cells that express GPR20, which in this case are GIST cells. And so that then gets taken up by the GIST cells, and the chemotherapy is brought into the cell, and this damages DNA and can cause the cells to die. So this is looking at using that homing signal of that antibody to bring it to GIST, and what are the effects of this drug more specifically on GIST cells. So again, looking at safety, what dose was the highest dose that could be administered safely, what the drug levels look like, and how well it worked. And this is an intravenous drug, not something we usually see for studies with GIST, but this drug was given intravenously every 21 days. There were 34 patients that were enrolled in the study. The side effects here were nausea, decreased appetite, low blood counts, fatigue, constipation, and vomiting. They saw tumor shrinkage only in 4 patients. And these were patients who had GIST that did not have KIT or PGFR alpha mutations. And really impressively is one patient with SDH deficient GIST, and the tumor also had an NF1 mutation, had a massive reduction, 87% reduction in the size of the tumor, then went to surgery, and on surgery, on pathology review, there was no viable tumor left, what we call pathologic complete response. This we never see with SDH deficient GIST. We do sometimes see with KIT mutant GIST and KIT inhibitors, but this was a really incredible response to this. Unfortunately, the study did not proceed to part 2, which is where more patients would be enrolled to evaluate further how well the drug can work, because the efficacy targets that were outlined to proceed were not met. And so right now, we don't have more information about how well this drug works in this patient population, but it raises some important questions. One is, is this an effective approach for SDH deficient GIST in particular? Can we use antibodies to bring drugs specifically to GIST cells to try to target them to get higher levels of drug into those cells? And in particular for SDH deficient GIST, is there a role for DNA damaging agents? Are they uniquely sensitive to these types of drugs? And that's an area that I think we're still interested in. And I will, comment in a few minutes that there's an ongoing study at University of California in San Diego looking at a drug called temozolomide, which is a chemotherapy drug that also can affect DNA in tumor cells in SDH deficient GIST. And then, so moving on to another abstract, this is from Dr. Therasader from MD Anderson, looking at the sequence of drugs in late line GIST. So, and this is really asking the question, it doesn't matter if you do ripretinib first and then move on to avapritinib, or start with avapritinib and then switch to ripretinib. So this is a retrospective study. So they're looking at patients that they've already treated to see how they've done. And there were 12 who received ripretinib first and then avapritinib, and 8 who received avapritinib first and then ripretinib. Now, I just want to be clear that ripretinib is FDA approved for GIST following 3 more kinase inhibitors, including Imatinib. And avapritinib is FDA approved for GIST that has PGFR alpha exon 18 mutations. It may be different how we use it in clinical practice, but that's how the drugs are approved for marketing. So it's, the use of avapritinib in this situation is something that we commonly do, but it's not consistent with the label of the drug. Importantly, what this group found was that the response rates, so the percent of patients who had shrinkage of the tumors, was not affected by the sequence. So whether you use ripretinib first or second, the response rate was similar, and whether you used avapritinib first or second, the response rate was similar. The progression-free survival, which is the duration essentially of how long the disease is controlled, was shorter for the second drug, regardless of which drug was used second. So the first drug tended to work for a longer period of time, and the second drug for a shorter period of time. And the overall survival, which means how long patients lived, was not significantly affected by the sequence. Again, meaning that the two drugs together seem to work for about the same amount of time as in either order. So again, this is, I think, somewhat reassuring that if we are using both of these drugs, it doesn't matter which order we use it. I just do want to point out this is a small study. So it's, as I mentioned earlier, these are often hypothesis generating studies that we see at ASCO. It's interesting. It does give us some reason to be able to choose among these drugs, maybe based on side effects rather than based on strict rules about which order to use them. And this also is not what we consider randomized studies. There might be one reason or another that one of the drugs was chosen that may not have been equal in the two groups of patients. And that's just one of the considerations that we also have when we look at data like this. And then the last two studies I wanted to talk about was the interruption of imatinib after prolonged imatinib maintenance. And this study from Dr. Kang from Asan Medical Center in Korea. And this, I want to, you may already know of this study. There's a study done by the French sarcoma group called BFR14. And there have been other studies like this too from other groups that randomly assigned patients with metastatic GIST to continue or to stop imatinib after 1 year of treatment, after 3 years of treatment, or after 5 years of treatment. And what they found was that when patients discontinued imatinib, even after 5 years of disease control, they were likely to have progression of their disease. Although they found that it also could be treated again if the disease started growing. Based on that, we very commonly continue patients with metastatic GIST indefinitely on imatinib, as long as it's working. So what Dr. Kang and his colleagues did in this situation was they interrupted imatinib in 77 patients after about 5 years on imatinib. But these patients had no detectable tumors. They may have been resected, they may have completely shrunk during prior treatment. So this is a little bit different than the BFR14 population in that there was no detectable on scans, there were no detectable tumors. They did find that after about 20 months of stopping imatinib, more than half the patients had their disease recur, so 61%. Then when they restarted imatinib, they were able to regain control in all of those patients of their GIST with control of the disease for almost 10 years. So they concluded that interruption may be considered, these are my emphases, with close surveillance, which means continue to look at them very carefully with scans, in selected patients who maintained years of imatinib treatment in the absence of gross tumor lesions, so nothing visible on scans, and have been on imatinib for years, especially for those who had complete removal of gross tumor lesions by local treatment. So it's those who had ablations or surgery for their disease. So again, a much different cohort than what was described in the BFR14 study, but something that's of interest for many of our patients who do have longstanding disease control and no signs of disease. And a similar evaluation was done by the Scandinavian group, here led by colleagues from Oslo, again looking at discontinuation of imatinib in patients with oligometastatic, which means a few metastases, who were in complete radiological remission, meaning no signs of detectable disease. This was a prospective study, meaning they enrolled patients in the study and then followed them. They had to have 3 or fewer metastases. It happens sometimes, but it's pretty unusual. Treated for imatinib for more than 5 years and had resection or ablation of all their metastases. They ended up stopping the study early because it was taking too long to accrue patients to it, because it's a rare patient population. So they enrolled 12 patients, and of those, 7 recurred when they stopped imatinib. It took about 10 months for them to recur, and overall the disease control rate was about 23 months. And just like in the Kang study, all of them received remission again, or achieved remission again when they restarted imatinib. So just to summarize, we see some interesting activity of 2 new agents in SDH deficient GIST, and raises the question, in particular for SDH deficient GIST, is there a role for chemotherapy? And as I mentioned, there's a study of temozolomide, which is an oral type of chemotherapy for patients with SDH deficient GIST. The order of ripretinib and avapritinib does not appear to be significant. And in cases of patients with undetectable metastatic GIST after prolonged therapy with imatinib, treatment can be stopped, but patients must be monitored closely for recurrence, and many will require reinitiation of therapy. So this is, I would say, is a complicated discussion, but one that's worth having with your doctors if this is of interest to you. It's not the right situation for everyone, and it's definitely a discussion about risks and benefits of doing so. And when we have this discussion, we always are taking account how well someone is tolerating imatinib into that factor, a factor into the decision. All right, so thank you very much, and I'll turn it back over to Sarah.
Thank you both for providing all the summaries from ASCO. That was well done. So I'm going to get started. I thought this was a really good question. Dr. Wagner mentioned that these drugs are considered chemotherapy drugs. How is it determined if an oral drug is considered chemotherapy?
Yeah, so I'm sorry, I don't remember the context where I used the term chemotherapy. We use drugs in many different names in very different ways, and I'm sorry if I got a little sloppy in how I used it there. Chemotherapy really means a drug that's used to treat anything. You could say that a blood pressure medicine is chemotherapy, but that's not really how we think about it. We tend to think about chemotherapy as the standard intravenous medicines that sort of, I don't know, I say it's the nuclear bomb approach, which is just these big DNA damaging, they affect your normal cells and your tumor cells, and you're really sick with them. And what we use to treat other sarcomas, what we use to treat lung cancer and breast cancer and colon cancer, those are things that we usually think of when we mean chemotherapy. And usually when we're talking about treatments that we traditionally use for GIST, we call those targeted therapies or kinase inhibitors because they block enzymes that are called kinases. The example of that drug that started with DS, the Suzanne George presentation, that was the antibody, the thing that was stuck on the antibody was chemotherapy. It's not chemotherapy we normally use intravenously by itself, but it's very similar to other chemotherapy that we use. That kind of, again, that nuclear bomb approach, but this is sort of like a smart bomb, right? It's homing in on those cells that express that GPR20 protein, and those are really quite limited in the body. And that's presumably why the toxicity was much more limited.
You know, speaking of targeted therapy, there was a question, is it advised to start a drug treatment without knowing someone's mutation? So who wants to take that?
I'll try to take that, and I think Andrew might be able to chime in afterwards as well. I think, in all honesty, in this day and age, when we have the techniques available to diagnose patients, not only just by the microscope slides looking like GIST, but to be able to get the molecular information, knowing what particular mutation that particular GIST may harbor, I think it's important because it has major implications on treatment, either in situations where we're giving the drug after surgery to prevent the disease from coming back, where, of course, we have data for patients with high-risk GISTs, we would use Imatinib, but that really would be limited to patients with KIT mutations, whereas also in patients who have advanced disease with a disease where it's no longer surgically operable, knowing the mutation, it seems, does help us in making some of these decisions. So my advice is, if you do not know the molecular signature of your particular GIST, I would try to find that out. Because it has implications.
Yeah, to add to that a little bit more, there are things that we can see as clues as to what the molecular signature would be based on where it started, what shape the cells are, and some other features. But that's the proof is really in the sequencing. I agree. But it can take time to get the sequencing data back. And in the setting of metastatic disease or disease that needs to be treated before it could be removed, I would start with treatment with Imatinib in those situations while you're waiting for the sequencing data to come back. For the adjuvant setting, the setting where patients have complete resection of their disease and they might go on imatinib to reduce the risk of it coming back, in that situation, you can wait for the sequencing data to come back, but also depends on how quickly you can get it. Some patients have had a very small biopsy where there's not enough material to do sequencing. In that case, we make our best guess about what it has. And the vast majority of patients with GIST have tumors that have KIT mutations, KIT exon 11 mutations. So that's usually why we would start with imatinib for those situations. And the other point I want to make is, Herbert presented very nicely the data on circulating tumor DNA that was from that big study, as well as from some other smaller studies. I don't think that is ready for standard clinical use right now. We're still talking about doing sequencing based on the tumor and the primary tumor, the activating mutation. The resistance mutation analysis is not yet standard. Our development of drugs in GIST is still sequential. The imatinib, sunitinib, regorafenib, ripretinib, avapritinib, or others, depending on where you are in that situation. Hopefully, we're going to get to a day where we will be using circulating tumor DNA or other measures to say most of your diseases has this mutation, let's use this, or using combination of drugs or other drugs that have a broader spectrum of activity. But I don't think we're quite there yet. That, again, is the science that we see at ASCO, and it's exciting, and we want to get there, but it takes time to prove that this approach actually is helpful.
So speaking of standard clinical use, there was a question that talked about another reason for drawing blood, but looking at plasma level testing, looking at the right dosing for imatinib. Is that being done in clinical practice in the US? Why or why not?
I don't think it is anymore. It had its moment. And I think what people point to is what we call a retrospective study. So it was a study comparing 400 to 800 milligrams of imatinib, where overall the outcomes of those two populations of patients were not very different. And then after the study was done, they went back to look at the drug levels, and they tried to see if there was a threshold, a drug level threshold, where if you're above that, you're more likely, or if you're below that, you're less likely to have benefit from imatinib. And somewhat arbitrarily, they picked this level where 25% of the patients were below and 75% were above, and that was about 1,100. I forget the units, nanograms per milliliter, nanograms per deciliter. I don't know what it was. It turned out if you were either on the lower dose or the higher dose of imatinib, you were equally likely to be on either side of that line. It wasn't that the higher dose patients were all higher drug levels and the lower dose levels were lower. But following that, there was some attempt to try to drive the drug to higher dosing. I think the FDA didn't like that so much because the studies that showed the benefit of imatinib were not based on drug levels. And so I think that's still in our standard practice now. In the US, we don't check drug levels. 400 milligrams is the standard dose to start with. And if people have toxicity, we use lower dosing. There's some subsets, perhaps exon 9 mutant tumors, where we might use a higher level in the metastatic setting. And at time of progression, actually the FDA label, the approved label says at progression, you can increase the dose to 400 twice a day. And I think we tend to follow that, but then adjust down if people are having side effects.
Okay, there's been a few questions that came, actually a lot of questions came in, so I'm not quite sure if you guys are able to spill over the hour, so we're gonna try to do our best here. There's been some interest in talking about the 3 versus 5 year adjuvant therapy for exon 9 and 11. Should patients be stopping after that time, or a lifetime use in patients without diagnosed mets? So feel free to talk about that as well.
So I think we're still waiting on data. I think our practice here, if you look at the data for patients at high risk of recurrence, The Scandinavian sarcoma group data looked at 3 years versus 1 year and showed that patients did better if they got 3 years of imatinib and not 1 year. But just like the 1 year versus placebo data, after patients stopped, they started progressing again with about a 6-month lag. So many of us interpret those data that patients at high risk of recurrence should be on for at least 3 years. And in the United States, I say many of us continue indefinitely as long as the patient's tolerating it. It's very unusual for somebody to develop a recurrence while they're still on imatinib in that adjuvant setting, unless they have one of the more unusual mutations. That's not the approach throughout the world. I think some places in Europe, for example, stop at 3 years, and probably some places in the United States stop at 3 years. And Herbert, I don't know what you do in Hong Kong.
Yeah, I think we also have to. We're in a very similar situation. We also consider reimbursement issues as well. Of course, the label is for 3 years, and any treatment beyond 3 years, patients will have to pay out of pocket, and that actually typically is the most difficult decision to make, because most of the patients, if they're able to do it for 3 years, it means that the side effects that they're experiencing are acceptable to them. They've all gone back to work. They're just going back to their daily lives. And most of them actually don't want to stop. But it's just a matter of the finances, which comes into play.
It's interesting. Somebody had asked about discontinuing sunitinib in the second line after 3 to 5 years of no detectable disease. That's a new one for me, so I don't know what your thoughts are on that.
I think in general for discontinuation, it seems as though the only studies that we really have is in the imatinib space in the first line setting. In all honesty, if there is a need to use second line treatment, I think then the overall plan, regardless of which drug you use and which line, is to use it until either there are issues in terms of tolerance to the drug, if there are too many side effects, or if it's not working well. So I think the suggestion would be, if the sunitinib is working for the particular patient and it's tolerating well, we should just continue for as long as possible.
Yep, makes sense. There was a question about any promising new drugs for imatinib resistant GIST in later line therapy after ripretinib, even within clinical trials.
At ASCO, there were not a lot of presentations. 2 of them are the ones that I showed you. Those were exactly asking that question. There are other drugs out there. We're still waiting on data. We presented and published actually a study combining a new KIT inhibitor in combination with sunitinib in later lines of study. That was a drug that was called PLX9486, now called CGT9486, now called bezuclastinib. The company that acquired that drug is combining with sunitinib in the second line compared to sunitinib, a study coming up for that. But what we looked at before, the idea behind this is exactly what Herbert was showing before, which was 2 drugs that had complementary activity across exon 13, 14, and 17, 18 that could be safely combined. So, that approach is one that we're still very interested in. And there's some other drugs that are in clinical trial now, but they're still early in the studies. And you certainly should, have your doctors, if they don't have the studies, reach out to any of us to talk about those study opportunities, because that is how we're going to find out about what drugs might be effective in those lines.
Somebody had asked about, I don't know if you're familiar with the Chinese company that acquired the drug from AstraZeneca, described as possibly a best-in-class KIT inhibitors. Is that one of them that you're referring to?
That is a study that's ongoing. I think it's called Nubei is the company, but it's it's early, so certainly very hopeful that this drug will be effective. And there are a couple others out there as well. This has been, for those of you who've been dealing with this for the last couple of decades, this has been one of the fantastic things about drug development in GIST, is the willingness of companies to continue to bring new drugs forward. And there have been many drugs that just haven't been better than other treatments, but there have been a lot of opportunities to find out how well they work. And along the way, that's where sunitinib and regorafenib and ripretinib and avapritinib have all come from. And those are the ones that kind of have shined through. And we're pretty confident that more drugs will come forward as the chemistry gets better in designing these drugs, as they can be engineered to be more effective against broader mutations, spectra of mutations, toxicity can be adjusted and things like that.
Just going to ask one last question, and this was something that really hit the news circuits, and it was that story about all the response of the rectal cancer patients on immunotherapy, and so I think a lot of cancer patients want to know, well, what does that mean for us? Will that work for our disease? So what are your thoughts in terms of just immunotherapy agents for GIST?
Go ahead, Herb.
Well, yeah, I think that news has been quite sensationalized throughout the last 1 or 2 weeks. And certainly for that particular group of patients, they were looking at patients who had rectal tumors with a microsatellite instability in their tumors, which is a particular signature found in multiple types of cancers. But I think in general, for GIST specifically, it's not a common change in our tumors. So my understanding is the fact that immunotherapy itself has not quite hit prime time for GIST. I believe there have been trials, or there's still trials ongoing, but we really don't have the data to support its use in our situation. Andrew?
I agree. It's a very common question, and it's a very good question. I mean, immunotherapy is effective in subsets of patients across many different types of diseases. And just to be clear, in most tumor types where it is approved and active, it still only works in about a quarter of those patients. There's some subsets where it's much more active, but we have a lot to learn about how to use it, what tumor types are sensitive. And in particular, what we're trying to do in many different approaches is how to take tumors that are not very sensitive and make them sensitive because of the promise of this type of approach. I agree. I mean, it was a wonderful outcome for those 12 or 13 patients. I mean, unbelievable response, but it's also something that we would have expected would work in the metastatic setting for those patients too, based on their tumor characteristics. So it has gotten a lot of press and excitement, deservedly so. But we wish we could get there with GIST. We're just not there right now.
I think on that note, I think we'll leave this as a ray of hope for the next year with all the things that have been talked about at ASCO and what we hope to see at the next ASCO for our disease and the developments with some of the trials that are also getting started this year. I'm hopeful that we're going to see continued advancements for our disease. And we just want to thank the two of you for your presentations today and your commitment to the GIST patient community. And it was a real pleasure to have you speak today. So thank you.
Thank you very much.
It's great being with you.
Have a wonderful day or evening.